Welcome to the Scientific Dose. Today we're taking a rigorous, highly detailed macro to micro journey through rheumatoid arthritis. We're going to deconstruct a terrifying biological betrayal, how a completely healthy joint is targeted and systematically dismantled by the body's own defense mechanisms, transforming into the perfect storm of inflammation.
Okay, let's dive into this roadmap. We'll start with the anatomy of joints, move into the immune triggers, explore the pathophysiology and cellular cascades, and finally examine the clinical perspective and treatments.
Section 1. Anatomy of synovial joints. Before we look at what goes wrong, just keep in mind our baseline. A healthy joint is a beautifully lubricated cushion. Two bones, capped with cartilage, fully enclosed by a capsule, and a synovial membrane pumping out this nourishing jelly-like fluid. That's our baseline.
When arthritis strikes, not all forms are created equal. Notice the color-coded hand diagrams here. The red and orange areas highlight rheumatoid arthritis, which is a systemic, highly symmetrical attack. It primarily targets the proximal interphalangeal joints, or PIP joints, and the metacarpophalangeal joints, the MCP joints, which are the knuckles right at the base of your fingers. If you've ever noticed someone's knuckles swelling first, this symmetrical attack is exactly why. Now contrast that with the blue and green areas highlighting osteoarthritis. OA typically affects the PIP joints too, but it completely spares the MCP joints, and instead targets the distal interphalangeal joints, or DIP joints, right near the fingertips.
Section 2. Immune triggers and susceptibility. So, knowing which joints are targeted, how does this whole immune cascade actually begin?
What flips the switch from a healthy, functioning joint to a site of chronic autoimmune destruction? Well, it's a multi-step progression. First, an individual usually carries specific susceptibility genes, most notably human leukocyte antigens, HLA-DR1 and HLA-DR4. But genetics alone aren't usually enough to tip the scales. In a fascinating and kind of surprising twist, the disease is often triggered by an environmental factor, like cigarette smoke, or incredibly, a specific pathogen, like Porphyromonas gingivalis, the exact same bacteria behind everyday gum disease. This environmental stress causes a modification of the body's own normal proteins, leading to a process called citrullination. And because of those susceptibility genes, our antigen-presenting cells, or APCs, suddenly get confused. They basically forget what self looks like and prepare to present these modified proteins to T cells as if they were dangerous invaders.
Take a look at the molecular lattice structure on screen. Citrullination is the chemical conversion where the amino acid arginine physically alters into a completely different amino acid, citrulline. This is facilitated by the enzyme peptidyl arginine deaminase, or PAD. So our own crucial structural proteins, like type 2 collagen found in cartilage or a cellular protein called vimentin, undergo this exact citrullination process. Their chemical structure fundamentally shifts. To our immune system, these essential joint building blocks now look like totally foreign invaders.
Section 3. Pathophysiology and mechanisms.
This structural misunderstanding is where the pathophysiology truly shifts into overdrive. Those activated antigen-presenting cells carrying the citrullinated peptides, they don't just stay in the joint, they migrate to the lymph nodes, successfully activating CD4-positive T helper cells and launching a systemic immune response. As these activated immune cells migrate back into the joint, they drive a massive proliferation of the synovial membrane, forming what we call a pannus. Now, this is an absolutely crucial term to understand. Imagine a delicate, thin membrane suddenly transforming into an invasive, expanding layer of granulation tissue. It's a thick, swollen, inflammatory exudate packed with fibroblasts, myofibroblasts, and immune cells. As highlighted by the magnifying glass inspecting the eroded bone in the diagram, this tissue physically infiltrates the joint capsule, eating right into the cartilage and eventually eroding the underlying bone.
Section 4. Cellular immune cascade. Now, what's really interesting about this next cascade is the sheer coordination of it all. This highly coordinated, albeit completely misguided, cellular attack begins with a localized cytokine storm. Macrophages are recruited into the joint space by the T cells, and they just aggressively begin secreting highly inflammatory cytokines, primarily tumor necrosis factor alpha, interleukin-1, and interleukin-6. These cytokines act sequentially. They flood the area and then directly stimulate the synovial cells of the joint to massively multiply and go on the offensive.
Let's detail exactly what these activated cells are up to. Notice how the illustration visualizes this. Fibroblast-like synoviocytes start producing destructive proteases, specifically matrix metalloproteinases, or MMPs.
These enzymes literally chew up the type 2 collagen network of the cartilage, just like the crumbling block you see here. At the same time, T cells in the joint are secreting interferon gamma and IL-17 to recruit even more macrophages. Crucially, the T cells also increase the expression of a surface protein called RANKL. This binds directly to RANK receptors on osteoclasts, the cells responsible for breaking down bone tissue. By activating the osteoclasts, the immune system guarantees that the joint damage isn't just limited to the cartilage, the actual bone itself erodes away.
But the joint tissue isn't the only battlefield. The synovial fluid itself is under siege. B cells, activated back in the lymph nodes, differentiate into plasma cells that secrete autoantibodies directly into the joint. These include rheumatoid factor, which targets the constant Fc portion of our own IgG antibodies, and anti-CCP, which targets those citrullinated proteins. These antibodies bind to their targets, forming the massive immune complexes you see floating and aggregating in the fluid. These complex structures activate a 9-protein enzymatic cascade known as the complement system, which promotes more inflammation and draws in neutrophils. The neutrophils arrive and essentially trigger an explosion of reactive oxygen species and more proteases directly into the fluid, completing the cycle of localized destruction.
Section 5. Clinical Perspective and Diagnosis. Let's shift gears and see how this microscopic devastation builds into macroscopic clinical symptoms.
Grounding this in clinical reality, take a look at the X-ray here, specifically where we've overlaid those aggressive, bite-like icons. Those mark the exact spots where RANKL-activated osteoclasts and the invasive pannus have literally eaten away at the joint architecture, creating severe bony erosions and narrowing the space until bone is dangerously rubbing on bone. You can also clearly spot the decreased bone density, which is a direct result of the proteases destroying the articular cartilage.
Check out the detailed sketches here. Over time, all this chronic destruction leads to some very specific deformities. In the hand sketch, you see swan neck deformities, where the proximal interphalangeal joint is hyperextended and the distal interphalangeal joint is flexed. The opposite of this is the boutonniere deformity, where the extensor tendon splits, causing the PIP joint to flex while the DIP joint hyperextends. You also frequently see ulnar deviation, where the fingers begin to angle visibly outward toward the ulna bone. And in the knee illustration, notice the swelling bulging posteriorly into the popliteal fossa at the back of the leg, creating a really painful fluid-filled sac known as a Baker's cyst.
Now, as highlighted by the organs on screen, this perfect storm absolutely does not stay confined to the joints. The inflammatory cytokines escape into the bloodstream, wreaking systemic havoc. In the skin, this leads to firm rheumatoid nodules. In the liver, the cytokines trigger the overproduction of hepcidin, which traps iron and leads to anemia. In the heart and blood vessels, the inflammation promotes atherosclerosis, significantly increasing the risk of heart attacks and strokes. In the lungs, fibroblasts can activate, causing interstitial lung fibrosis. And finally, there's a highly dangerous triad known as Felty syndrome, where a patient suffers from rheumatoid arthritis, an enlarged spleen, and a severely low white blood cell count, making them highly susceptible to life-threatening infections.
Section 6. Treatment and Biologics. So how do we halt this perfect storm of inflammation?
With such a devastating, localized, and systemic cascade, intervening is a massive challenge. As symbolized by the protective shield on screen, foundational, long-term management relies on DMARDs, disease-modifying anti-rheumatic drugs. We're talking about medications like methotrexate, hydroxychloroquine, sulfasalazine, and leflunomide, which work to suppress the generalized immune response and slow disease progression. Now, for acute, sudden flares where the joints become extremely swollen and painful, clinicians rely on short-term use of glucocorticoids and non-steroidal anti-inflammatory drugs, or NSAIDs, to rapidly extinguish that immediate inflammatory fire.
But the real breakthrough in recent decades? Biologic response modifiers. We can now literally match targeted therapies to the exact cytokines and cells we just learned about. Look at the breakdown here. Infliximab, etanercept, and adalimumab are engineered to specifically block tumor necrosis factor alpha. Rituximab is a monoclonal antibody that zeroes in on and suppresses the plasma-producing B cells. Anakinra is an IL-1 receptor antagonist, directly blocking interleukin-1. Tocilizumab binds right to the interleukin-6 receptor, halting its downstream effects. And abatacept works by preventing T-cell co-stimulation entirely. By understanding the exact pathophysiology, we can basically snip the wires of the inflammatory cascade one by one.
Which leaves us with a truly exciting vision for the future.
As we continue to decode the microscopic immunology of the synovial joint, we're rapidly moving closer to an era of hyper-personalized medicine. Just imagine a future where we don't just guess which drug will work, but rather sequence a patient's exact molecular cascade, matching precise biologics to their unique inflammatory profile. Could mapping the individual journey from susceptibility gene all the way to citrullonated protein finally transition us from simply managing this perfect storm to actually finding a definitive cure? It's a profound frontier in immunology, and one that gives incredible hope to millions. So how close are we to neutralizing this perfect storm for good? That's what we have to keep watching.